Hi everyone, thank you OETA for the opportunity to present. After hip fracture, older adults face high risk of death, with 30% dying within a year and up to 10% during hospitalization. Surgery timing is a risk factor, but delays are inevitable during the period of high demand, presenting us with tough choices. Imagine two patients admitted with hip fractures today, and only one operating room slot available for tomorrow. Guidelines recommend surgery within 48 hours, but they don't say who goes first when demand is high. Some studies show better survival after early surgery, but this depends on individual health and care needs. So, who should go first? To address this, we took the personalized medicine approach. We attempted to find who gets to gain most from shorter surgery times. We calculated probability of benefit, a new measure of how likely someone is to survive because of early surgery. We looked at 140,000 hospitalizations with first hip fracture treated in Canada between 2004 and 2012. Half of the study population was over 85, three-quarters women, a third were from home care or presented with serious comorbidity. Most surgeries were fixations, done in teaching and in community hospitals. Nearly two-thirds were within 2 days of admission. Surgery within 2 days was found to save one life per 100 operations. But averages don't tell the whole story. That's where the subgroup analysis comes handy. We create groups to isolate the impact of surgery timing from other factors. And the literature suggested to control for factors like age, pre-fracture health, surgical readiness, type of surgery, hospital type, and calendar year. Using a combination of these variables, we split hospitalization records into 64 groups. This chart displays the impact of timing in different groups. Each dot is the mortality difference between early and delayed cases. Colors tell us about hospital and procedure type. Top and bottom labels arrange groups by patient health and age. And the red line is the average effect. The impact of surgery within 2 days varies quite a bit. 7 groups have it well above average, but you can see that 2 days were critical for some and less so for others. For example, the first dot on the left shows the effect 6 times the average level, and dots at the bottom indicate no difference. Subgroup analysis isn't new, but we took it further. In each group, we looked at the probability of early surgery benefit. And here's our thinking. When presenting with injury, patients fit into one of 64 groups. And for some, in each group, shorter times means changing prospect of mortality to survival. So we ask, how many survive with early surgery but not without it? And the proportion of such patients in the group is the probability of benefit. Why it matters? Because we can rank subgroups and find groups with a higher proportion of their patients who benefit when surgery is not delayed. Certainly, it's a theoretical quantity. After all, we are comparing potential outcomes of hypothetical timing scenarios. But we can find its range. The maximum value coincides with the mortality in delayed cases, and the minimum is difference in mortality between delayed and early surgeries. This time, the chart displays bars, not dots. Each bar is a range of possible values, and the proportion we are looking at sits somewhere between the top and the bottom of each bar. In 14 bars, the minimum is above the average line, but some bars show the maximum value of 7 to 13%. So who benefits most? We think these 4 groups on the left. Why? Mortality difference is bigger than the average and the worst outcomes when surgery is delayed. Specifically, patients over 85 with multiple health issues benefit most from expedited surgery, whether it will be in teaching or community hospital, whether it's fixation or arthroplasty. We looked beyond averages, and we saw patients for whom surgery timing converts mortality to survival. Our personalized medicine tool quantified their benefit of having surgery sooner, and we predict that booking them first will improve survival at discharge. Operating room managers can now expedite cases where timely intervention truly matters. Thanks for watching.